So this video is about reproductive disorders. We'll start with a review of some of the systems. So we'll look at male reproductive system. The main organ of reproduction in men is the testes. It's where spermatogenesis happens. I'm not going to review the intricacies of it, but the testicles produce the sperm. The sperm moves into the epididymis where it matures and develops the ability to swim. From the epididymis, it goes into the vas deferens, where it gets transported up to the urethra. There are 3 glands that contribute to the ejaculate, and the fact that the sperm has no cytoplasm, no ability to store glycogen or any energy source, all they have is mitochondria and the flagella and the nucleus. They have to be nourished on their journey by secretions, and it's from these glands. So the seminal vesicles secrete a lot of that, the energy that it takes to propel the sperm. The prostate gland provides the environment, and the bulbourethral glands, which are called the Cowper glands, secrete a clear mucus that is for lubrication and for cleaning out the urethra of any urine that's still in there. The penis is the organ of copulation, and it's about the delivery. So, testes with the vas arete, the epididymis, the vas deferens coming up over the bladder and behind the bladder, where it joins with the seminal vesicles. Goes through the prostate, where it joins with the urethra, and out the bulbourethral gland is there. Hormones are important. As you know, both men and women release the gonadotropin hormones in the pituitary. They're FSH and LH. In women, FSH, which is follicle-stimulating hormone, stimulates the follicles, and the follicles will grow, and so it's the development of the oocytes. Luteinizing hormone causes the corpus luteum, and which is really endocrine in nature, and so it makes a progesterone. In men, FSH similarly is about producing the gametes, the spermatogenesis, and luteinizing hormone is about hormones stimulating testosterone production. Testosterone is necessary for the maturation of sperm, for males' secondary sex characteristics. It's used in protein metabolism, muscle development, bone, things like that. So we're going to start with some congenital abnormalities. There are congenital abnormalities of the penis. More common than you'd like to think. What's supposed to happen is the urethra is supposed to exit at the tip of the glands of the penis. In some individuals, the urethral opening, it will happen on the ventral or the dorsal surface of the of the penis. If it's on the ventral surface, it's called Epispadias. If it's on the dorsal side, it is Hypospadias. So there's problems with this. Incontinence, infection can be a problem. It's, I don't know how much it impairs reproductive capability, and I guess it depends on how far along. The hypospadias happens, my understanding is it happens more commonly, and it can be an opening right at the base of the penis, right near the testicles. So it's surgical reconstruction. This is seen when the baby's born, and it's corrected very early. In third world countries, maybe not, but in Canada, for sure. There's also disorders of the testes and the scrotum. So in normal fetal development, the testicles develop up close to the kidneys, and then they descend until they enter the scrotum proper. So, and that happens around the time of birth. With some people, it doesn't. The testes fail to enter the scrotum, and we call this cryptorchidism. Orchid is the Greek word for testicle. Crypto means hidden, so hidden testicles. And the name orchid for testicle came before they named the flower that. There are ectopic testes, so this positioned outside the scrotum. The big problem with this is blood supply, temperature, things like that. So you can, and just the plumbing. So you could get degeneration of the seminiferous tubules, impaired spermatogenesis, and a risk of cancer. So this is all corrected early. So here's how it's supposed to happen. So if the testicle remains stuck in the inguinal canal or in the pelvis, or in the upper part of the scrotum, it's called cryptorchidism. Probably more common are the seals. And if you remember, seal just means a fluid-filled sac. So there can be a hydrocele, and that's basically water. It's interstitial fluid, collects in the space of the scrotum itself. So between the tunica vaginalis layers. So it could be congenital, it could be an injury, infection. The biggest problem with the hydrocele is that it puts pressure on the testes, and that pressure, on top of being uncomfortable, can compromise blood supply, and that can lead to ischemia and maybe infarction. So it has to be corrected. They drain it off. Spermatoceles, the cyst contains fluid and sperm, and it happens between the testes and the epididymis. So what happens is the rete testi is dumping its contents, instead of into the epididymis, into the space between. If this happens, it's surgically removed. It can be a developmental abnormality. Varicoceles happen, and they're very common. And this is really just a dilated vein. So this is like a varicose vein, except it's in the veins that surround the spermatic cord. Normally, there's a plexus of veins that surround the spermatic cord, and it's about warming the blood that's going back to the body and cooling the blood that's going to the testes, because the testicles need to be a couple of degrees cooler than body temperature in order to function. So if there's a back pressure, these veins can dilate to the point where the valves get compromised, and once the valve's compromised, you end up with a varicosity. And there's an awful lot of men have this varicosity around their spermatic cord. It can cause impaired blood flow. It changes the temperature. It decreases spermatogenesis. It says here it requires surgery. It would have to be a pretty major one before they would do surgery. 9 times out of 10, it happens on the left side, and that's because, if you remember your anatomy, the right testicular vein goes back directly to the vena cava, to the inferior vena cava, where the left testicular vein drains into the left renal vein, and then that crosses the spinal cord, or the spinal column, and then enters the vena cava together. So there's a little bit of back pressure. It also means that venous drainage of the left testicle is always a little bit less than the right testicle. So the left testicle is always a little bit heavier and tends to hang a little bit lower because of that extra weight. But it means that the left, if any of these problems exist, it's usually with the left. And that's just an artifact of normal anatomy. Now, the testicles don't normally move. They're normally fixed in position within the scrotum, now with various ligaments. What can happen if those ligaments fail or don't form, the testicle can rotate. And as it rotates, it will squeeze the veins, the arteries, and the spermatic cord. If that happens, we're going to get ischemia. We're going to get swelling of the scrotum. We can get testicular infarction. And it's a medical emergency when this happens. It has to be treated. It's usually treated surgically, but it can be treated manually if it's caught early, and they can spin it. My understanding is that they can manually turn some of them around, and that buys time to schedule surgery to fix it in place, because you wouldn't want to have it happen again. It's just called testicular torsion. So this is what a hydrocele looks like. So this is what a varicocele looks like. The varicose veins in the plexus. This is torsion. This by far is the bigger medical emergency. Okay. The prostate is a particularly vulnerable gland. It is in its position, it is right in front of the rectum. The urethra passes through it. It fills the space between the bottom of the bladder, the trigone of the bladder, and the floor of the pelvis. It can be palpated through the rectum, and because of this, it is in a fairly vulnerable spot. If there's urinary tract infections, they can end up in the prostate. If there's any sort of a perforation or anything getting transferred from the rectum, that can end up in the prostate. So yeah, it's there. So prostatitis is an infection or inflammation of the prostate gland. We can have acute bacterial or chronic bacterial, so those would be from infections, or we can have non-bacterial, so it's from other things. It's inflammation from tissue damage, that kind of thing, or asymptomatic inflammatory, in which case it's an artifact. It's just found. So, prostatitis, it's usually found in younger men. Sometimes, especially the bacterial, acute bacterial, is related to STIs, STDs, but it could be urinary tract infections as well. So if it's acute bacterial, the gland is tender and swollen. And there's bacteria in the urine or in the ejaculate. If it's non-bacterial, the urine has a lot of white blood cells. In the chronic bacterial, we don't get as much enlargement, but it burns to pee, dysuria. There's an increased frequency and urgency in voiding. But as you know, that's very similar to the urinary tract infection, and cystitis in the bladder. So it's hard to tell the difference, really. So it's often E. coli. Sometimes it's Pseudomonas or Streptococcus faecalis. It often comes from intestinal flora, and I'll just leave it to your imagination how that could maybe get there. It's putting penises where they probably don't belong. So if there's repeated E. coli, then it can become a chronic infection, and it's opportunistic, and it's the normal flora of the gut that does it. So normally we see prostatitis in younger men. They say age 35 or younger. It's often associated with urinary tract infections. It can happen in older men because we're going to see benign prostatic hypertrophy is a pretty common thing in aging. And there's a problem of emptying the bladder from there, and so washout doesn't happen as well, and so we can end up with a bacterial prostatitis on top of the benign prostatic hypertrophy. It's often associated with STDs or catheterization. It can also happen from bacteremia, like it can be seeded from the blood. So, how do you know when you have it? It's dysuria, urinary frequency, and urgency. So that's because the prostate, as it inflames, will actually squeeze on the urethra. It's difficult to empty the bladder, and so you will pee more often with less pee. And there's a certain amount of urgency to it because it the inflammation makes you think you have to pee, and it burns when you pee. There's no force in the urinary stream. Now, if it's bacterial, you're going to get systemic symptoms of an infection. So that's fever, chill. There's pain involved with this, and it refers to low back pain a lot. And this is one of the distinguishing factors between benign prostatic hypertrophy and prostatitis. In BPH, the pain happens during urination and is kind of more localized. The pain of prostatitis is more consistent. It's there all the time. It's the pelvis and low back pain. Can lead to abdominal discomfort. Fever, malaise, and anorexia happen here. So systemic muscle aches. So you feel sickly. You feel like you have an infection someplace. And really, I was taught that the presence of pain is an indicator that that there's a problem here. And because it refers to low back, I'm constantly on the lookout for it. And when I take my history, if a young man comes in with low back pain, it's always on my list of differential diagnosis. It's something that I think about and question. I don't necessarily do tests for it, but it's always there as a consideration. So if we know there's bacteria because we culture it, we use antibacterial drugs, so antibiotics like Cipro. If it's non-bacterial, anti-inflammatory drugs, and prophylactically antibacterial, because if it's inflamed, maybe it will you're going to have a retention of urine, and then maybe it can turn into a bacterial infection. Balanitis is a fungal infection of the glands of the penis. It's sexually transmitted. So this is more a problem with men who are not circumcised, that have a foreskin. And when the partner has a yeast infection, a vaginal yeast infection, it can transfer. The candida can transfer and infect the glands of the penis. It gives a burning and itching. So we use topical antifungals for it, kind of the same as athlete's foot. Okay, BPH, look at these numbers. 50% of men over 65. So if we go to my high school graduating class of, there was about 100 guys, 50 of them have BPH right now. probably a bunch of them have had prostate cancer. It's a very real problem. What it is hyperplasia of prostatic tissue. So everything gets bigger. It's excessive growth of the prostatic tissue. And because of that growth, and the fact that it's like a donut around the urethra, it compresses the urethra and it causes urinary obstruction. It is hormone-based. It's a problem of balance between estrogen and testosterone. Men produce a little bit of estrogen, and the testosterone causes growth of the prostate. The estrogen limits it. If the testosterone takes over, the imbalance happens and the prostate grows. It doesn't predispose you to prostatic carcinoma, which is a good thing. But it's not, lay people don't understand that. Prostate is prostate to a lot of people. So the prostate gets enlarged, and it's palpable enlargement. So with the annual physical, there's usually a rubber glove and some lube involved, and it gets palpated on rectal examination. One of the problems with BPH is that it can lead to frequent infections, urinary tract infections, more than prostate infections, but it can lead to prostate infections as well. The obstruction causes problems with distended bladders, the ureters, hydronephrosis if the urine backs all the way up to the kidneys, and can cause renal failure if it's bad. Most men can actually avoid a fair amount when they have this. It's difficult to do. It takes a lot of pushing, and it's very, very difficult to empty the bladder. So frequency goes up. That's why you see older men don't pass a public washroom very often. It's like, well, there's a washroom, I best just go for a pee while I got a chance. It's interesting, the drug that they give for BPH is called Flomax, which is the best drug name I've ever heard because it maximizes your urine flow. So you get hyperplasia, a little bit of hypertrophy in the prostate, compresses the urethra, obstructs the urine, difficulty in peeing, especially to initiate it. You get incomplete emptying, so that can lead to more frequency. It can lead to bladder distension and maybe kidney damage, or it can lead to infection because you don't empty the bladder, you don't get washout, which can end up in pyelonephritis. So those are complications. Most men don't have complete obstruction, and so that's the extreme case to have these complications. The signs are this obstructed flow, a difficulty in starting the flow, and then a difficulty in ending it. So there's a little bit of dribbling. How do you deal with the dribbling? Well, it depends. You get decreased flow strength, so therefore you get increased urgency. You have to get up in the night to pee a couple of times. And it can cause dysuria, burning, but it doesn't necessarily. So smooth muscle relaxers Flomax is the drug of choice. The Avodart is to slow enlargement. And in bad cases, surgical removal of the glands will happen. Okay, cancer of the prostate. The most common cancer in men over 50 years of age. And the third leading cause of cancer death in men. 1 in 6 will be affected. I can probably attest to that, in that when I look at my group of friends, it's probably about 1 in 6 have had prostate cancer. One of the things that's different about prostate cancer from hypertrophy when they're doing the rectal exam is that the benign prostatic hypertrophy starts in the center of the gland around the urethra, whereas cancer will be a tumor on the surface of the gland. So it palpates as a bump on the gland, a palpable bump on the gland, rather than an enlarged boggy feeling. There's various aggressiveness to it. Most of them are rather slow growing. And when it happens in older men, urologists often joke that you're going to die with prostate cancer rather than from prostate cancer. You're going to die of something else before the prostate cancer takes you. The tumor is really dependent on testosterone to grow. So a lot of times the treatment is to remove testosterone. I know of a couple of guys that actually have had their testicles surgically removed to reduce the testosterone to stop the cancer, the prostate cancer. The biggest problem is that it can be metastatic. It's invasive within the prostate itself and in the surrounding tissue, but it's the mets that are the real problem. So my dad had a very slow-growing form that wasn't very aggressive. He had it treated. He was the first person in Canada to get a new treatment. And, this would be in about, I think it was in '97. It went away, and then it came back for him in 2015. He eventually died of lung disease and not of the prostate cancer. My uncle, however, had an aggressive form that ended up metastasizing to bone and then to lungs, and it was the secondary tumors that took him. So there's probably some sort of a genetic component to this, but it's not very well established. It could be a history of recurrent prostatitis that might lead to it. So these bouts of inflammation causing histological change that eventually becomes cancerous. High androgen levels seems to be a bit of a problem, and that's something that the guys at the gym that are taking testosterone and growth hormone and insulin-like growth factors to bulk up should be considerate of, because one of the side effects of those anabolic steroid You want to look like a professional wrestler. Well, one of the problems is Mr. Happy doesn't work, and then prostate doesn't work properly either, and can end up with cancer. So there's a palpable hard nodule. As it grows, you get a problem with urine stream and hesitancy, frequent urination, and recurrent UTI. So it's got a lot of the same symptoms of BPH, except the palpation is different and the outcome is very different. So a big tool in looking at this is blood work, where we're looking at the PSA, the prostate-specific antigen. Until recently, it was very common. Most men, every physical, got their PSA done. And now it's, because of the number of false negatives, they're doing it less, but I request it every time because you kind of want to chart it. You want to see what your baseline is, and so that you're looking for change in the PSA. If the PSA is indicating, so if the PSA is going up and it's indicating that there might be a problem here, then they do ultrasound and they look for the tumor. They do digital exam, palpation, to see if they can feel a nodule. If either of those are indicative that there might be, then they biopsy it with a punch biopsy and look at it, and they can tell if it's a tumor from the biopsy. And then if there is, then they tend to do bone scans to look for metastasis, because usually the first place that it metastasizes to is the spine, lumbar spine. So, so surgery is one of the treatment options to just remove the prostate. The problem with removing the prostate is that it leads to incontinence and erectile dysfunction and an inability to ejaculate, and that can be pretty traumatic to a lot of men. Radiation is probably the preferred way to go. External radiation, where it's like any other tumor, or this implanted pellets. And this was what my dad had, is the first one in Canada to have the implanted pellets. And it worked for him for over 20 years. If the tumor is of a certain type that's sensitive to androgen, then orchiectomy, so removing the testicle, is effective, as well as some drugs. Or a lot of men end up taking estrogen to try and create that balance. And again, that's what my dad ended up doing for the last couple of years of his life. They're working on chemotherapies. I don't know very much about it. I don't know how effective it is. It's radiation and anti-testosterone drugs seem to be the first choice. Surgery if it's far along. Chemotherapy if there's metastasis. Testicular cancer is reasonably common, 1 in 300. It can happen in younger men. So testicular self-examination is how it's found. Now, normally it doesn't take very much coaxing for young men to be palpating their they notice a growth or a lump. And it's funny, it's one of those things that men will go to a doctor to get that checked out pretty readily. They'll ignore coughing up blood, but oh my God, if there's a bump in my balls, I'm going to have that checked out. It seems to be increasing in number, so that makes everyone think that there's a environmental factor. Nobody is completely certain whether it's hormonal, from growth hormones in food, that kind of thing. Don't really know. It's a solid tumor of the testicle. There could be predisposing factors like cryptorchism. There could be hereditary things. It's probably environmental agents that is causing it, causing the uptick anyways. Remains to be seen. There are palpable, hard, painless, unilateral bumps. Testicles may get enlarged, feel heavy, aching. If the tumor starts secreting hormones, it probably will start to secrete estrogen, and you can end up with gynecomastia, which is really growing breasts. Ultrasound palpation is what they look for with CAT scans. Computed tomography is CAT. Computer-assisted tomography is what CAT stands for. Look at the lymph vessels. Orchectomy is the treatment of choice. If they can do radiation or chemotherapy if they think there's metastasis. We'll end this video here and do a second video on female reproductive.